Do you ever get a song? This is completely unrelated. Do you ever get a song stuck in your head and it's like the only thing that plays in like the cranium? I have that going on right now. I've had it for the past 2 days, and it's also why I'm like I feel like I'm scatterbrained because this one song, like
What
one
song?
melody line, I don't even know. It's this song that I found. It's very I don't want to say obscure. Um, Angel in Your Eyes by I don't even know. Sia Doblo Labra. I literally don't know. I don't know how I found it. I was shuffling through my like songs on Spotify and it came up. I'm like, who are you people and why? Like, what is this? And now like it's good. It's just kind of weird. Um,
Is that by Sia?
yeah. Like it's good. There's just like one specific I don't know. It's good, but it's kind of weird. It's not really my style, but like it is stuck. Like we were on a call yesterday and I realized I started humming it halfway through the call and I was like, what song is oh God, it's still the same.
When I get stuck on a song, sometimes I'll just keep playing it, and my kids hate that. They're like I can go weeks at a time, and when I'm driving them to school, I'm just playing the same song, and they're like, "Why do you do that?" I'm like, "I have no idea."
Welcome back to another episode of 22 at the Lips. I'm your host, Alexis Hardwick. Whether you're happy about that or not, here's where we are, friends. Um, if you've been an active listener and slash or viewer of this podcast and the YouTube platform and Apple and Spotify and wherever else you want to find us, thanks for joining us along this journey. And if not, and this is your day one, welcome. I don't know how you've gotten to this point in this journey and how you stumbled upon us, but we are the podcast from EMS personnel to EMS personnel and healthcare personnel and field first responders and the everyday average bystander who works at wherever you work that is interested in this field. Welcome. So, I usually always have somebody on the podcast that either has some kind of cool experience or credentials behind their last name or has done something in the field that is extraordinary and interesting. And somehow today I've encapsulated all of that in our very special guest of honor, Dr. Peter Antevy. If you've never heard of him because you live under a rock in this field, he not only is he a medical director and obviously emergency medicine physician with the field focus of pediatric pre-hospital. Um, he is a medical director. He, like I said, you'd have to live under a rock to not know who this man is. Hundreds of accolades and awards behind what he's done, and so many other things that I know I'm going to miss along the way if I try to highlight. So, from the man himself, Dr. Peter Antevy. If you want to tell people who you are, what you stand for, the floor is yours, my guy.
All right, Alexis, thanks so much for having me. First of all, and very excited that you were able to launch a podcast, keep it going, provide information to everybody out there. I'm a big believer in using social media and getting information out that way. So, a little bit about myself. So, like you mentioned, I started off in Los Angeles getting my pediatric training. Went to Pittsburgh and got my pediatric ER specialty training. So that's a total of 6 years for peds and pediatric ER. But along the way, I found myself in LA flying in a helicopter. In Pittsburgh, did a lot of ground ambulance, a lot of helicopter in Pittsburgh. And for people who don't know, Pittsburgh is like the mecca for EMS for a lot of folks. A lot of great people work there. And if you're a PDM or EM resident, you're heavily involved in EMS. Came down to Florida in 2005, and I continued educating my local EMS folks, just because I love EMS and I wanted to give them more training. And then in 2010, I was working as a pediatric ER doc for since 2005 at a level one trauma center, children's hospital. And in 2010, one of the nurses came to me and said, "Hey, Pete, that fire department that you've been helping, is looking for a medical director, and they told me that they wanted you to submit an application. And I said, Maricar, I'm a pediatric ER doc. And she said, just submit. So I ended up submitting, went up against 15 other people, all of whom who had EMS experience. I had zero, and I somehow got the job. And from that moment in 2010, I recognized that that's where I'm supposed to be. And you may ask why? It's because the people in EMS are, salt of the earth, smart people who see a problem and they want to get it fixed right away. There's no red tape. And I recognize that my personality, which is like to be at the tip of the spear of innovation, it was very easy to innovate in EMS compared to the hospital. So I ended up going from one EMS system to another EMS system and adding another EMS system. And I find myself today in 2023 with a number of systems that span from um, all the way down south as far as Miami-Dade, Broward County, Palm Beach County, and now I'm up in Brevard County. So the total number of paramedics is somewhere between 2,500 and 3,000. The population we cover is about 3 million. And I find myself working with incredible people, uh, making incredible saves. And right before I came on the call with you today, we just had another great save of a 37-year-old guy in the softball field. And I mean, we saved his life right on the pitcher's mound. Before we got to the ER, by the time we got to the ER, the guy was fully awake and talking. So, why I find myself loving this profession is because it turns out that's where we save lives. And for years, for many years, I thought it was those guys are just ambulance drivers, and they bring them to the big hospital where we save lives. But boy, was I wrong. So that's why I find myself loving EMS, and kind of 80% of what I do day to day, and find myself really enjoying it.
I'm only going to take away about 10 points for calling us ambulance drivers, but it's you didn't know me
Right.
better. So,
Back then, that's exactly right. Back then, it was those folks are just bringing people to us, and believe it or not, many ER docs today still look at us that way. It makes me really upset. Um, and in fact, that call I just talked to you about, there was an ER doc on the softball field screaming at my guys, and thankfully we just ignored the guy because we ended up staying on scene. By the third shot, this guy came out, but he was having what we call CPR-induced consciousness, where we had to give him ketamine, which is in our protocol, by the way. And so we had an ER doc on the field. There's no concept of what we do and how good we are. And so I have to give him a call. I got to find out who he was and give him a call. But it was a perfect kind of contrast to the typical ER doc out there in the world who has no idea what a high performing EMS system looks like. Their protocols and what they do in the hospital are years behind what we do in EMS. So just another example of where EMS is shining uh, much greater than what they're doing in the hospital. So,
um, and I feel like a big part of that is the kind of like we talked about the agency I work for now, which the medical director, which was really really cool. Having that medical director who not only has the what's the word? Pretty much like has the back of the providers that
mhm.
he has oversight over and makes the protocols for and stuff like that. But like his ability to have their back and create these protocols that are more innovating in the field and more helpful in a way. And things that like the medical director understands the actual field work of the personnel versus somebody that is so far removed from actually like knowing what is even in the back of the ambulance and our capabilities. Like, for instance, not throwing shade, but the agency I worked at when I didn't live in Louisiana, great agency, but very limited medications and protocols. And it wasn't necessarily the medical director's fault, just because the EMS is just a little further behind in the modern times, more or less. But having somebody that is, like you talked about, the tip of the spear and adaptive and in a way almost pushing the envelope because we're so quickly adapting and evolving. I mean, EMS is a baby field in comparison to, I mean, nursing and like the hospital setting and stuff. But like having somebody that's able to like look around, realize what's up and coming, what's working and what's not working, and adapt to that. It makes a difference for those who are in the field and operating, but also with like the morale mindset of like, okay, well, if we're doing these things and they matter and they have data and statistics and research behind them and they work, and then we're still evolving, like it kind of gives almost that like confidence boost, especially like you're talking about in that call with the providers who have to, I mean, with their own education and training and field experience, understand the why behind the protocol and the things, but also with an ER doctor looking at them and saying to do the things. I mean, that's an MD. That's somebody with years of study, years of experience, blah blah blah, all that stuff. But having that, um, what's the word I'm looking for? That confidence to, yeah, confidence to like look at them and, I mean, ignore them, but also know within yourself like I'm doing the right thing for my patient because my protocol says. With that backup, I mean, I guess confidence again, but like with that backup of like, this is what I'm supposed to be doing, and I know this is right. It makes a world of a difference. Mm, congrats on the call. Kudos to the team that was in the
Yeah.
call. Like, man,
Yeah, you know what? I mean, everything you said, I love what you said. And what I would tell people who are listening to this to think about is how comfortable do you feel calling your medical director? Because what I've noticed is, now that I'm with a number of different agencies, the most recent agency that I joined, um, they had a culture of not calling the medical director. And that says to me that there's a cultural problem there, because if the medical director is not fully engaged, if the medical director doesn't have give the paramedic or EMT full open access to them, then that suggests that the type of care that's being delivered and the oversight that is there is not connected well. So if you have an agency where you're out there and you feel like you're all alone, and the only thing you hear back from the medical director is when things go wrong, and it's something that's punitive, all of a sudden you have a paramedic who is kind of is coming to work maybe in fear that if something happens tomorrow, I'll call and I don't have anyone to reach out to, or I'm not getting feedback that's going to help me in a positive way. You end up having a very bad kind of overall career. And I'll give you a perfect example of this. About a week and a half ago, Palm Beach County, we get a call that a lady's giving birth. Nobody likes that call. um, then, so, in Palm Beach County, we have, we call them rescues or ambulances. So the ambulance is on its way, the engine's on the way. We also have an EMS captain. The EMS captain is um, kind of functions like the physician, right? We have 9 battalions in Palm Beach County, and we have one EMS captain per battalion, and they cover kind of a large portion of geography, and they only get toned out to the Delta and Echo calls. So this is a call that they got toned out to, and en route on the MDT, they got the update that the friend who's at the bedside says that there's 2 feet sticking out. So it's a breech delivery. This EMS captain is has never delivered a breech. So what does he do? He calls the medical director, right? And he gets input from the medical director. He happens to have called my partner, Dr. Shepke, who walks him through it. So he gets to the call. he sees that he feels the umbilical cord still pulsating, and he says, we're just going to get to the hospital, which is 20 minutes away. But 5 minutes into the call, he loses the pulse. So if you wouldn't have had that ability to call the medical director, because there's two maneuvers that you really need to know when you're delivering a breech baby. And I'm not going to go through it now, but I posted this on Twitter for everybody's knowledge. But you have to be able to know how to get the arms down one at a time, one arm, then the other arm, and then know how to get the head to flex. So when the head flexes, the baby can come out. But without that knowledge and without the ability to call, that baby would never have come out. And that could have ended this guy's career, not because he would have been fired, but because he would not have been able to get this baby out. So the baby was delivered. He did successfully deliver the baby. And so it's those types of things that, if you're an EMS, you have to have full engagement of the medical director for the individual call, and also for education, training, protocol development, all the meetings we have to be at, all the data we have to look at. You really need a fully engaged medical director. So very important.
You about to have me moving to Florida to work
Come
under
on
those
down.
agencies because good Lord. I
Come
mean,
on down. Yes.
I've done a couple of cool things in this field, but I mean, not that I ever want to deliver a breech baby or deliver another
I
baby ever
know.
again in my career. But
Nobody wants to do that, right?
dude, the
And
time I did,
you cannot request the call you get, right? Alexis, that's the problem.
unfortunately, um, if I could, it would be 90% Meemaw fell in the kitchen and possible broken hip. No, the one time I've delivered a baby in the back, we got all the way to the hospital, 20 something minute drive, all the way to the hospital. We pulled up to the parking lot and she gives that one final push and the head is out. And then we get under the bay and she delivers it. And like it was a cool experience because I delivered a baby, whatever. It was also gross and it was so much. And then I had to write the second report for the baby because it was technically in our ambulance. Never again. Um,
Right. Did they,
but
did they did they name the baby Alexis? Did they name
no,
the baby after you?
unfortunately, I was
No.
like, I told the mom, I was like, even just like a middle name, like just something. She was like, I'm sorry, baby, we already decided. I was like, whatever.
That's too funny.
But speaking of babies and pediatrics, Dr. Antevy, why did you focus on the pediatric pre-hospital field? Because I mean, we have the knowledge, we have the training, especially as paramedics, like the further extensive caring for neonatal resus and pediatric calls and stuff like that. However, I fall under the category of pediatric calls scare me, and it's probably lack of confidence in those calls. Like I know what to do, they just still make me a little nervous. So why did you focus on that? Because not only are they like, is it the difference of the weight based medications and they're still growing and there are just so many other things, but like they are a class of little peoples all on their own. It is so different from your just regular 50, 60, 70-year-old patient. Like it's a whole different ball game emotionally and physically and mentally. Just what was the draw, my guy? Because no offense, I don't get it, but I'd love to hear why you did.
Yeah, that's a very good question. There's a lot to unpack in there, and the way that I look at it, I really transitioned how I think about the critical pediatric patient. Whereas when I was in training, they said, like you just said, kids are different, and if you even dare to say that kids and adults are the same, they get really upset with you. Part of the problem is that we completely um, scare people into thinking that that kid is very different than the adult when in truth they're not. So I'm going to give you a protocol, and you're going to tell me what's the difference between the adult and the kid. Okay, so asthma, adult and kid, They both get they both get beta agonists. They both get steroids. There's no difference. Anaphylaxis. Yeah, they both get epi, Benadryl, Salumedrol, albuterol, normal saline. There's no difference. Hypoglycemia. They get dextrose. So cardiac arrest. They get high quality CPR. They get epi. If they're in shock low rhythm, uh, you'll give them lidocaine or amiodarone. There's no difference. The only difference in all of these protocols is in the symptomatic bradycardia protocol, where in pediatrics, they want you to give a cardiac arrest dose of epi, which is epi 1 in 10,000, 0.01 milligrams per kilogram, whereas in adult, they don't allow you to do that. So if you really look at it from 30,000-foot view, there is no difference. So I would say starting off by kind of retraining the brain that when it comes to what we do, there's nothing different. What is different are the following things. There's the assessment is very different because you have kids who can't tell you what's wrong with them. So you have to be very good at assessment. You have to be very good at, from across the room, looking at someone and understanding their ABCs just by using your own eyeballs. Very important. Number two, you have to be good at improv, meaning that you have to be able to engage the family, give them confidence. And the only way to engage the family is by making eye contact. A lot of people, if you're really nervous because they scared you so much about kids, en route to the call, your heart rate's 200. When your heart rate's that high and you walk onto the scene, the last thing you want to do is make eye contact. If you don't make eye contact with the family, they lose the confidence in you right away. The tension starts to rise. You're nervous. They're nervous. All of a sudden, you just like, let me get out of here. So it turns out that although the medicine is the same, the skills and techniques that are used in pediatrics, the soft skills, are very different. So what we do and I do is I teach people the soft skills, and all of a sudden it opens the door to them to actually just handle the same medicine as they would have in the adult. So there's a couple of things that we can do to maneuver people towards great pediatric care. And really that's where I found my niche is to help people get to the promised land with kind of using a different route, if you will. Um, I love the critical pediatric patient. I love speaking to families. I love the high stress situation and bringing down the stress. I found myself wanting to be in those situations. And now that I've been doing it for such a long time, I've been able to kind of understand how I can help people get to that same point. And that's what I've focused on, um, with the creation of Handtevy, and the courses that we've put out and the education I put out on YouTube and etc. is to help people understand that if you learn those soft skills, everything else opens up.
Since you brought up the Handtevy, I think one of the most I don't want to say like light bulb moments that I've had in this field, but definitely in the top five was I didn't even hear about it. I was working with my partner Cody, who he's now a flight medic. Dude is incredible, absolutely incredible guy. But he he um, he went into EMS pretty much with this idea of like he wants to give back because his daughter actually was like a super sick infant, neonate and stuff like that. And he just remembers like being in the back of the ambulance during like a transport or a transfer or something like that, and being so helpless. But like seeing the paramedics and stuff like work and know what to do and all of this stuff, he was just like, I got to give back. And like anytime he would talk about it, he would start tearing up. So one shift he brought up the Handtevy method, and I was like, "What do you mean it's doses on the hand?" He was like, "No, bro, look at this picture." And he went through the ages with the dosages and stuff like that. And I literally, like, I went home. I don't have it anymore because it's ugly, but I drew this giant hand on a poster and I wrote out every single one of them because I was like, there's no way. There's no way it's this simple. I mean, I don't
Yeah,
remember it by heart just because now, like, I have my tea tiny notebook with all my drug dosages right then and there. But it was that moment where, like, in paramedic school, I remember, but especially like in the field, hearing the stuff and seeing it, where I was like, it is that simple. And it kind of took not too much, but a little bit of that fear away from pediatric calls because it's like, okay, it's the same
yeah,
medications that we're giving big people. So the little people can have it. It's just a different dosage for understandable reasons. So
yep,
Dr. Antevy, the man himself, co-founder of the Handtevy method. If you want to talk about it, if you want to go through it real quick, give me a synopsis. Like, and then especially, how did you come up with that? Like, it blows my mind to this day that it all is. It's incredible. So if you want to go ahead and spill about it, I'm ready, my
yeah.
guy.
Well, I tell you, I was embarrassed for many years to tell this story because the reason I had to do this is because I made a tenfold medication error in 2005. It was a girl, I'll never forget, she was in room 4. Nurse, the nurse, her name was Sky. She came out and she's like, "Gotta come in here, kids in anaphylaxis." And back then, she brought me out at this hospital that I just started working at. She brought out the Roslow tape. Um, and I had never used it because in Pittsburgh and in LA, we never used length based tape. We used age. So she points to the Epi 1 to 1000. I say, give it. And we gave her 2.1 mLs intramuscular instead of 0.21 mLs. And the girl's heart rate went through the roof, blood pressure went through the roof, her hives went away. But she ended up needing to go to the ICU. She ended up doing okay, thank God. Um, but I made that mistake because I was using a tool that I'd never used before. Listen, it's a great tool. Been a great tool for many years, and Dr. Broslow is considered a legend in the field. But I knew that day when I made that mistake that there was a problem. Fast forward another month, and we had a code that morning. It was a 7 a.m. code, and I'm at the head of the bed. And, I'm the physician in charge, and I'm I'm going through the stuff. We're doing CPR, and the nurse hands me again the Broslow tape. But because people were stealing it, someone decided to put it into a big encasement of wood. So it was like this big 6 foot piece of wood, and I was holding it literally at the head of the bed. Like if I turned around, I'd kill 2 people. That's how bad it was. And I'm looking at it. I have no idea what to do with it. So I ended up putting it to the side. The kid ended up, the kid ended up dying because it was one of those cases where the kid had been dead for probably a couple hours. Long story short, I said to myself, "There's something wrong here." Where I trained at two of the top 10 children's hospital in this country, and we never used the link-based tape. And now I'm here at a, level 1 trauma center children's hospital, and they're giving me this tape. So I called up my mentor, Bob Hickey in Pittsburgh, and said, "Bob, big problem here. They're giving me this link-based tape." I said, "You are one of the authors of PALS." He says, "Yes." I said, "But when you read PALS, there's nothing about using age, which is what you taught me." He's like, "Yeah, it's a long story." I said, "Bob," I said, "I'm ready for any story because I'm having a big trouble here." So, I ended up kind of listening to Bob, and when I hung up the phone, I said, "You know what? I got to figure this out." So, over the next coming months, I struggled, and then finally, I said, "I got to figure this age thing out." Took a piece of paper, I wrote down, all the ages, 1, 2, 3, 4, 5, 6, 7, 8, whatever, and then I said, "You know what? There's too many ages. Let me just make 5 ages." So I ended up figuring out 1, 3, 5, 7, and 9. I looked at all the formulas out there, and I figured out the kilograms that I could associate with those ages. So 1 year was 10 kilos, 3 years was 15, five was 20, seven was 25, and nine was 30. So I was like, whoa, you know, that's pretty simple. So I wrote 1, 3, 5, 7, 9, 10, 15, 20, 25, 30. I said, okay, now what are the drugs I would need during a code? You know, epi. Back then we still used atropine. Back then we still used bicarb. So I wrote all these drugs down. I think I ended up having like, 8 medications. And then I just did the calculation where I looked at the volume, not the dose per kilo, which was confusing to me. And I realized that a 1 year old, 10 kilo kid, if I just moved the decimal point over from the 10, that was my epi and amiodarone dose. So 1 ml. I said, wait a minute. So a 15 kilo kid, 1.5 ml of epi, 1.5 ml of amiodarone, like holy cow. And then I started looking at all the other doses, the atropine, the bicarb. Again, this is many years ago. And I was able to look at these drugs and it just jumped out of the paper. And I said, wait a minute, I don't need anything anymore. Now I figured out what Bob never told me, which is that's why all he needed was an age. So that was like 2006, 2007. I had this thing figured out. And the nurses were like, whoa, Antevy, you gotten much better. Like, what happened to you? I was so embarrassed I didn't tell anybody. But in each code, I was just like 2 ml of that, 1 ml of that, 1.5 of this. And the nurses now were like, okay, he's finally in the rhythm. Um, Marikar, who's the nurse that, kind of has changed my life forever, she said to me, hey, Pete, whatever you're doing, when you give that lecture on drowning next week, can you teach them this little trick? And I'm like, I hesitated. I'm like, fine, because I never told anybody about it. I gave this talk a week later on drowning. I had 2 slides at the end with the hand, and I taught everybody the method. I said, 1, 3, 5, 7, 9. Taught them how to do the epi and the amiodarone, and then I ended the lecture. And right afterwards, and remember, there were doctors in the room, paramedics, nurses, 200 people in the audience. 50 of them stood in line to come talk to me. And I'm like, man, was that drowning talk that good? But they're like, no, we just want those last 2 slides. And that's when I said, okay. I come home to my wife and I'm like, listen, I got to tell you this story. So she's like, well, why don't you make a little card? So I'm like, all right. So I went into my computer, made a card, went to FedEx. It was called Kinko's back then. I laminated it and I made like 20 or 30 of them, brought them to the ER. Within literally an hour, we're gone. I'm like, what just happened here? Everyone just came and just took these cards. So we ended up finding a printer. We started bulk printing them. So I came to the ER with like 100 of them. All of a sudden, people were coming down from the OR. They were coming down from the PACU. The cards were gone. Then I started getting calls from across the country. Hey, we want you to give this little talk you gave. I'm like, okay. Anyway, make a long story short, I was giving away thousands and thousands of these cards. I was giving lectures all over the country, all on this hand method thing. People were calling me months later. You wouldn't believe I saved this kid. I got a call from Las Vegas. I was at your talk. You gave me your card, and I saved his life. Anyway, just to make a long story longer, um, that's how it all started. And till today, people call me up and say, I mean, obviously now we have created an app, and it's not just 8 drugs; it's 40 drugs, and kind of Handtevy has become a lot different than just the 1, 3, 5, 7, 9. But we still teach it today in our courses. It's pretty cool.
um, if you want just one more anecdote to add to, I'm sure you're thousands and thousands of anecdotes of how it's helped providers. Um, we responded to an urgent care. It was a 1 year old who was seizing, and so I'm not gonna say I do this for every call, but like for any seizure patient call, I'm like, okay, by the time we get there, it's probably done, whatever. And it's especially during the call, like by the time we drop the Versed, they're probably gonna be done. So like, I mean, still it's a 1 year old, so I'm still like sense is heightened a little bit, but I'm also like, we'll see what happens. But the notes kept coming in of he's still seizing. It's been 15 minutes. And I'm like, oh dear God.
Mhm,
And so
mhm.
the agency I work for, we we have not yet adopted like using the full resource of the Handtevy method, but we have a protocol in our protocols where you grab the Barstool tape, fling it out, you find the like where the patient is on the colors and stuff like that. I don't know how else to simplify that. You find the color, and then we have these sheets of based on the color, like the mill's already done. So in a way, I mean it's like a Dollar Tree version of the Handtevy method, but whatever. Um, my medical director, you didn't hear that from me, but um, so it's cool, but also like I was thinking to myself, I mean, this is great to have, but I need right now to know the dosage. I don't have the Broslo in front of me. I don't have this kid on the stretcher with the Broslo. I don't have this in front of me. And I literally on the way, I'm like, thank God I know this hand heavy method. And I mean, I knew it, but also like pulled it up real quick. So I'm like, I'm kind of dumb sometimes. I don't want to make a fool of myself of all these moments. This one. So, and I mean, it came in clutch, my guy, because as soon as the firefighter came out and he had the kid like in his arms, I mean, the patient wasn't seizing in that moment, but I mean, gosh golly, if as soon as he was on the stretcher and I went ahead and I was like, if I have to waste it, sorry. I started drawing the Versed, and what as soon as he got on the stretcher, I already had like the Versed like drawn up, and as soon as he hit the stretcher, because we don't carry Ativan, but as soon as hit the stretcher, I was like, oh, doop. And so after the call, like, I mean, as we progressed, like I obviously went for my agency's protocols and stuff because I'm not trying
Yeah.
to never mind. But after the call, my partner's like, "How'd you know that from the get go?" And I was like, literally, I said, "Let me show you something," because she's about to go back into paramedic school. So I was like, "Let me show you something, little mama. Let me pull something up. I'm about to change your life." And then I called Cody after. I'm like, "Hey, remember that time you showed me the hand tapping method? Like, thank you, my guy, because so it is an incredible resource. And I mean, not only is it a thing where it makes everything click as far as medications and stuff, but it's also it mitigates a lot for me. It mitigates a lot of that like cognitive. Um, I don't know how to say it, like that overwhelming cognitive information block because there's already so much else to think about. There's already so many other things to take in consideration. If I don't have to med math in that moment and I can do something that the patient needs, and especially in a pediatric setting, and I mean, this is a pride thing, but just being blatantly honest, something that I don't have to sit and pull my phone out and calculate a dosage for in front of parents who, for another thing about pediatric calls, for a parent to call 911 and slash or even in the hospital setting to render the care and aid that they can provide for their child to someone else is I don't have a kid, so I don't get it, but I would imagine if it was my dog who is my baby, um, if I had like when I do that at the vet, because like he needs a shot or something like that, it is such a helpless feeling. So
Yeah.
to to be able to better instill confidence in that parent of I know what I'm doing, I know the exact drug dosage that I need to have your kid stop seizing in this moment. I mean, if nothing else, it's worth it for that. But it's also, I mean, patient care and stuff. But just that
Yeah.
one less thing of I got to go through and calculate drug dosages, and especially again those little even just seconds that it matters because my kid went from me having to drop my verse and then try to calculate mentally or on my calculator and wait blah blah. That's seconds less that he stopped breathing after a seizure. That second less that he it just
Yeah.
I'm a huge fan.
Well, I'll tell you that everything you just said there. Like if you really like break apart that entire sequence, it turns out that the most important part of that entire sequence was prior to arrival on the scene. your performance on the scene reflects on your pre-arrival ability, right? So what we've noticed now, our system is now used in 2,500 cities across America. We're also in Canada. We have lots and lots. We have hundreds of thousands of people using our system. What we hear over and over again, and now what we teach because we see it and we've learned is that the most important part is the pre-arrival. So if you're en route to the seizure call and you use midazolam and you know that the concentration of midazolam that you carry is the 5-in-1 or the 10-in-2, same thing, and you know you're going to a 1-year-old patient and you know the volume that you're supposed to give this kid within 30 seconds of you leaving the station, now you have let's say I'm going to make up a 6-minute ride to the call. You already know the dose, right? Done. Check. The cognitive, that's what we call cognitive offloading. That's what you mentioned. So now I'm done with that. Now I can think to myself, okay, what does the pediatric seizure patient really need? What they really need is to have their airway managed with my 2 hands, right? So you open the airway. If they need, obviously they all need oxygen. At least I would recommend initially. Some of them need an OPA because they can tolerate an OPA. Some of them need a BVM. So the first thing they need is not midazolam, Versed. The first thing they need is basic BLS stuff because that's what we need to kind of stabilize them. And then in comes the Versed at the dose that you already knew before you got there. And because you didn't have to pull out a length-based tape, and because you're able to speak to mom and dad and look them in the eyes, you're able to calm the entire situation down and not get so crazy about the seizure to want to then run off the scene. So everything that you just mentioned, if you break it down, very, very important to have a tool that prior to arrival on scene, you have all the answers so that you can actually function appropriately on the scene. So the people who don't understand pediatrics and pediatric dosing, they don't get that, what I just said. And they're all trying to focus on giving a tool that can only be used after arrival. Like you had mentioned, you take out the tape, which we have a tape too in our system, but you only use it like 10% of the time. If you're having to take a tape out in front of mom and dad, get to the color, go to your Dollar Tree spreadsheet, right? You're done. You're never going to do that in front of mom and dad because you're going to look amateurish. And the parents are going to say, what do you mean? You're doing a calculation in front of me with a spreadsheet? These aren't the right people for me. So I cannot stress how important it is in EMS to have the answers before you get to the scene for your confidence, for your ability to treat the patient, make an assessment, talk to the family, treat the patient on scene, get a better outcome. And that is, in essence, what we've learned, what I've learned with respect to treating the pediatric patient. So, you know, we cannot, kind of overstate that enough. And I think that's the important part of what the people in the academic centers still don't get about pediatric care in EMS.
To kind of highlight that, I want to say in any call in general, but I would say even more, especially in pediatric calls, because even still, like that confidence with the parents, you need to go in. No, I mean, it's looking like you know what you're doing, looking calm. I mean, what's the thing about be like a duck, like floating on the surface and taking like heck underneath, whatever it is. But you need to have that mindset of like, I have the knowledge, I have the training, I have the confidence, and I need to look like it because these parents are riding on me to know. So especially on the way to pediatric calls, but uh, me and my partner do what's called pre-gaming, and it's not every single call, not in the alcoholic sense, but um, I would get fired. Also, that's not good for the patient. So, and it's not every call, just because some calls it's like, okay, like we kind of know we're going to keep our head on a swivel anyways, just because typically it's the calls that we're like, oh my gosh, it's this again. And then we get there, we're like, oh, they're coded. Haha. So, but on the way to those calls when we're pre-gaming, it's literally just so that we kind of that game plan of if we see this, then we do this. If we see this happening, we're going to do this. If there really is, I mean, even site calls, if there really is somebody that's cutting up, I mean, I'm going to go ahead, circumstance depending, have my hand on the ketamine because I'm not doing this today. Like pre gaming is so important. It's that pre notion of what we're doing. And I mean, I keep a little notebook to write notes on calls, but also primarily for when you get those pediatric calls, if you know that they're seizing, if you know it's this. I mean, if even on the
Yeah.
way to we didn't it wasn't actually thankfully a pediatric cardiac arrest of a 2-year old. I literally got my notebook. I'm not driving, so I mean I've done it before. Like I was driving around, I was the one driving the calls, and a call came out and I looked at my partner. I'm like, we got to switch because I need to write dosages down. um so on the way to that, what wasn't a pediatric code, literally get my teeny tiny little notebook, write dosages right then and there. So as soon as we walk in, I mean, I have it on a piece of paper. I glanced and I know the things. It, especially with the Handtevy method, it's already spelled out for you. You just whatever.
Yeah.
Um,
And one day when you have the app, you'll just open the app and you'll say 2-year-old, and everything will be right in front of you, and it'll take about 12 seconds. And that's I think a huge thing where um, immediately in about to the call, you can bring your heart rate down, you can bring your confidence level up, you can pregame appropriately, and that's what I think every EMS system should strive for, whether they use Handtevy or not.
we're working on it. Um,
All good. It's all good.
The 22 at the Lips podcast is designed to support, not replace, the relationship that exists between a practitioner and his or her medical director. The views and opinions expressed in this podcast are those of the host, guest, and not necessarily of Master Medics. The information provided during this podcast is intended for educational and informational purposes only. It is not a substitute for your approved protocols.